introducing Dr.
Thank you.
Madeline Paul, and she is a nephrology expert at the University of California, Irvine, located in Orange, California. She serves as the principal investigator for UC Irvine in the National NIDDK funded study titled The Family Investigation of Nephropathy and Diabetes. This multi-center research initiative aims to uncover the genetic factors contributing to diabetic nephropathy across diverse ethnic groups by employing various strategies to identify susceptibility genes. Tune in to Dr. Paul's Kidney Talk podcast episode, Having a Baby on Dialysis. Dr. Paul, welcome, and we're glad to have you here. If you're ready, I'm going to go ahead and pass it over to you.
Thank you. Yes. Now, um, I'm not sure exactly what format you all wanted to do.
Okay.
Today, I am tasked with talking about the warning signs of infection,
Yes.
when to seek care, don't ignore an infection if it can be dangerous. And
Yes.
because it's 15 minutes, and I'm told that people think PowerPoint slides with medical information are boring. So do you. We think they're wonderful, but there you have it. So today I am going to give just a 5-minute introduction,
Okay.
and I think we're supposed to have interactive questions. Is that reasonable?
That is absolutely reasonable. I will ask everyone who is attending right now, please, in the chat or in the Q&A, if you will make questions for Dr. Paul. She's a wonderful resource. I encourage you to submit those questions, and whenever she has finished presenting, we will field those questions to her. So with that said, we're all ears.
Perfect. Well, so I struggled with how to present this topic. Of course, being a nephrologist, not an infectious disease specialist, I had some concerns. So I decided the simple way to do it was to give a little introduction about infections and then have an idea about different settings. I mean, infection signs can vary depending on the type of infection, the location, and also for us, what underlying problems, we say comorbidities, people have. So I thought, okay, let me divide this into what our patient group might be. For example, infections in dialysis patients. When we think of hemodialysis infections, we focus on things associated with vascular accesses. Some people have those tunneled central venous accesses, which many people like because they're not getting poked, but they're associated with higher infection rates. And the other accesses, fistulas or AV grafts, also have risks of infection. And because these catheters dash accesses are directly connected with the vascular system, the concerns is when people have infections with typically bacteria that goes right into your blood. So things to consider when you're discussing things. If you have a central tunnel catheter, people are supposed to be looking at the exit sites and things like this, but be alert, see what you have. If you're seeing that exit sites beginning to look redder or swollen or painful, you should alert the team that's doing your dialysis to look at it and see what can be done about it. This is not an emergency that you have to go to the ER at 3 in the morning, but it's something that should be alerted, and they should be looking at that too. And I know all of you have been, if you have a central venous catheter, have been told all the ways you take care of it. Don't be touching the tips. Don't be sitting in a bathtub or swimming. Cover it when you're taking a shower. And typically, patients should be masked when they're accessing the central catheter for dialysis. For the fistulas and the grafts, if you start seeing swelling areas around it, some sort of a small drainage at the side of where people were cannulating, or a scab that isn't going away, you should make sure that the dialysis team sees it. It could be infection and they could address it at the time. But again, this is not something that's an emergency. What's an emergency that you need to take care of immediately is a fever, chills, night sweats. These are, if you're feeling very fatigued, muscle aches, these are signs of bacteria in your blood, and that you should address immediately. Okay. What about peritoneal dialysis? Same idea. Your catheter that's coming out, there's an exit site. All the people with doing peritoneal dialysis have been educated up the wazoo how to take care of these and do your exchanges. The same idea. If you start seeing drainage, if you start seeing swelling that hurts in the tunnel, that should be immediately discussed with your team when you're seeing them. Don't wait for the monthly peritoneal dialysis clinic, but address it sooner. But things like a cloudy effluent, abdominal pain that's unusual, different, that's if you're touching, it's really hurting. These are signs, and fever, of course, chills, signs of a peritonitis and should be addressed immediately. Those are the ones you would need to call your team right away. And typically people have antibiotics to take care of that. Then the big one also for us now is the transplant team. And as you know, early transplants are at higher risk for infections than later transplants. And everyone is watching that very, very carefully. In that setting, right initially, early on, there's infections with viruses. You're being evaluated frequently in the first weeks, months of transplant. As you people have been transplanted know you're given some antiviral medicine, or you're being checked for virus infections like CMV. So you just have to be meticulous about adherence with the medications and being checked, whatever they say you have to go in every month to get this blood work done. You have to do that. In the prolonged, those patients who've been transplanted more than 6 months or a year, again, infections are a problem, and you have to be alerted to these things. If the typical things, if you have fever, if you have chills, if you have myalgias, you should not be sitting around waiting to see how that goes. You should immediately contact your physician and or go to an emergency department to make sure that any infection is addressed immediately. So with that, I wonder if people want to have some kind of discussion or chats. I should mention urinary tract infections, which are so common in our population. And everybody knows already, if you're having pain on urination, if you're seeing bloody urine, these things, they suggest a urinary tract infection that should be treated. The challenge in the urinary tract infection world in our population is when people have what's called asymptomatic bacteriuria. So some of our patients will always have bacteria in their urine. And the challenge there is not to treat them. Every time someone looks at the urine, sees white cells, cultures it, and sees bacteria. To treat only when they have symptoms. Because if you overtreat, then you're going to start setting up people with resistant bacteria that can be more problematic in the future. So with that kind of introduction, I wonder if people want specific things discussed.
Okay, Shar has her hand raised, so I'm going to
Okay.
see if I can allow her to talk. Shar, it's asking you to unmute. If you can do that, then we can hear what your question is.
She's still muted, yeah.
Yeah, while she's doing that, I'll go ahead and throw out a question, Dr. Paul, and that would be about PD patients and swimming. I've heard from one extreme to the other. I bet you have too. And I'm just curious because I've read that you could go swimming in salt water. Well, I live in the Gulf of Mexico, which is salt water, and I know on a regular basis we get flesh-eating bacteria. So I
Yes.
think if somebody was immunosuppressed or even just compromised or brittle, that it could cause problems. What's your viewpoint on that?
So first, okay, I'll preface by saying, look at this face. I'm old. So yeah. So we're old conservative people. For decades, we would say to people who had peritoneal dialysis catheters, the same as the tunneled central venous catheters. Okay, fine, you're going to take a shower, make sure it's covered, you don't get wet. But we would say absolutely not. Going emerging, no baths, no swimming. And in my mind, the risk of getting infection may have been overstated in the past.
Mhm.
However, when you have a serious infection, the consequences are significant. And we can't figure out why people really need to swim that badly, honestly. If you needed to swim that badly, if you're a swimmer, then don't do peritoneal dialysis, would be probably something to consider. So the simple answer would be don't do it. Don't do it. Take your shower. Don't be emerging in water, immersing in water. That's that's the standby recommendations.
Okay, all right. Shar, we're still waiting to see if you can unmute. We do have a question. Oh, here it is in the chat. I
Okay.
used
Oh,
to
cool.
use Tegaderm to cover my catheter, plus I had the nurse wrap the legs, no infection for 6 years. I think
Excellent.
it's on Incenter, I believe.
Yeah. Well, and that's again evidence that careful management of these catheters, PD catheters, the exit of central venous catheters, can result in incredibly wonderful outcomes. And so I congratulate you. Well done.
Very,
Yeah.
very good. So we're waiting for another question. While we are, I'll go ahead and ask another one. Dr. Paul, I'm a dental hygienist, and I've been around a while as well. I've had my transplant for 25 years, and I've worked in dentistry since 1981. And since that period of time, for transplant recipients and for dialysis patients, the need or lack of need for antibiotic pre-medication
Mhm.
before invasive dental procedures is like a pendulum. It swings back
Swings.
and it swings forth and it swings back and it swings forth, and it's confusing not only for providers but it's for patients too. And so again, I see as a dental health care provider, I see people who are susceptible, possibly because they have a dental disease in their mouth, like gum disease or a lot of cavities. And then if you added on top of that, maybe again, they might be someone who isn't in the best of health. They're not stable. Maybe they're a brittle diabetic. Um, what do you recommend for people to find out about whether or not they need antibiotics before they have any type of invasive dental procedure?
Well, what we typically follow is anyone who has the cardiac valvular problem, calcification, any sort of abnormality that's been identified, which is very common, particularly in chronic kidney disease 4 to 5 dialysis patients. They would do, we would do prophylaxis. Now, and that's been established not by nephrology, but by the general cardiovascular teams and through studies in the past. What's not well studied, but typically implemented by the nephrology crew, is people who have vascular accesses. Okay. If you have fistulas, if you have if you have any of these things, we'll give prophylaxis before dental procedures. So now comes the challenging question. What are we going to do to someone who doesn't have a catheter, who's been transplanted for 20 years and has stable renal function and no cardiac valvular abnormality? You could probably not use pre-treatment unless you thought there was significant problem, right? They have such bad gum disease, something that's going to cause bacteremia that's severe that you would do it. And here the risk benefit is so tenuous, right? What's
Right,
the risk of taking 2 grams of amoxicillin? Got, it's not very high unless you have an allergy.
right.
So that's the idea. We also will do it, by the way, even though it's less clear, I'll give it to peritoneal dialysis patients because they have the PD catheter in place.
Right, right. I've always felt
Yeah.
like it was something that you couldn't take a cookie cutter approach to it, that you have to
Yeah.
look at each patient, not just from a medical standpoint, but their dental as well, because that's part of their medical. And,
Yeah.
what you don't want is somebody to end up with an infection, right?
Yeah. That could be devastating. Yeah.
Lori wants to know what are some of the reasons people say you seem to have, what are some of
Let me
the
speak
reasons?
English. I think the
You
question
can,
is what are some of the reasons that a patient has been in your care that has an infection of why they didn't pay attention to it sooner. I sadly had a friend who had a cardiac arrest because she didn't want to go to the doc. She didn't want to get up and go. You don't feel good.
oh,
And I just wanted to hear some real life stories that you've experienced because we don't have a lot of room for error.
you're right. Yeah.
And
And see,
it's no fun to get up when it's raining and it's cold out and you don't feel good to go to the hospital, but you have to. You can't wait around when you have a brewing infection because sepsis is a killer.
right. So that's, yes. If you had fever, chills, feeling of terrible myalgia, you can't wait. And typically people sometimes, like you said, they just don't want to bother with it, or maybe they're depressed and have had enough. And but the once you get a bacterial infection in your blood, for sure, the risk of having severe consequences, dropping your blood pressure, becoming septic, is high. That's what you have to attend to urgently and immediately. And the hope is to prevent that, to get an infection before there's that level of problem. Right.
And then the
I
other
don't know why people don't do it. Beats me. We're nephrologists. We only know numbers. We don't know how people feel.
Well, and then the other thing, that's really interesting is that, preventing infections, of course, because, there's
Yes.
a lot of antibiotics I can't take anymore. I'm either become allergic to them. I mean, I still have treatable antibiotics that can care for me, but the importance of not taking antibiotics when you don't need them because
Yes.
that is something like, oh, I got a cold. No, it's a virus. Antibiotics do not treat a virus, and it's still widespread that antibiotics will make people feel better, and they make you sicker because they make you resistant.
Yes. That's why I said about the urinary tract infections, which is the typical one we're involved with. Every time your primary care doctor looks at your urine, if you're one of those that have asymptomatic bacteria and says, oh, look, there's bacteria, and no, don't treat it unless they're symptomatic. And in that situation, we spend, you're right, Lori, half our time blocking the treatment.
I know
Yeah.
the nasty one bacteria I've had a few times is that E. coli bacteria.
Yeah. Well, yeah. And they live in the urine. Yeah. I know. Yeah.
Yep, and sometimes it gets to you, and it's it's crazy. And I think you mentioned that I don't have symptoms when I have a UTI. So I really have to pay attention to what my urine looks like because I can start to tell a little bit and I'll go get tested, but I don't have traditional symptoms for a
And
urinary
again, yeah,
tract
yeah.
infection.
And if you're sterile in between those things, that would be reasonable. If not, right. And then, but if you feel myalgia and not necessarily having pain when you urinate, that might be your symptom, or you feel something. Yeah.
Right.
So
I
then
feel a little
those are tough
fatigued.
calls.
I
Those are
feel a
tough
little
calls.
fatigued. I feel a little bit off, but I can't quite pinpoint it.
Yeah. And those are tough cases where you have to make clinical decisions based on in the what's happened to the patient before and etc. But yeah.
Okay,
There was
we have
something
two more
about
comments in
CMV.
the chat.
Yeah.
One is I had CMV from my transplant and it destroyed most of my colon. I didn't realize I had it because the symptoms I was having resembled Crohn's disease, which I've had for about 30 years. There was no fever or chills. So maybe you could explain to people what CMV is and what are the symptoms associated with that.
CMV is a virus that many people have, they've been exposed to before, but there are few who do not have it. So the highest risk for a kidney transplant is when you are CMV negative, that you never saw it, and they give you a kidney transplant from a person that was CMV positive. CMV stands for cytomegalovirus. And you can get symptoms like sore throat, fatigue, there can be GI symptoms, there's all sorts of things. Transplant teams are extremely familiar with CMV, and there's all sorts of strategies how to manage the high risk patient, the CMV negative person that got the CMV positive kidney, and those that are everybody CMV positive, they've had it before. And so each program has their process. We at UCI typically give the antiviral for a certain period of time. Other places screen you for CMV in the blood, okay? And if you start to get higher numbers, then they give you the antiviral. But the symptoms are multiform. They can be GI. And I don't know how soon she had the symptoms after the transplant, but noting the symptoms to the team would have hopefully alerted them to look for CMV. And then they would have given antiviral therapy because it is treatable. So that's on the CMV, what I would say. But typically, sometimes the patients, they decide not to take the antiviral because there's so many medications, it's annoying. Or they're supposed to be doing surveillance blood tests, which are similarly annoying, and they don't show up at the right time, so they're missed. So I tell you, just follow the regimen, and it's typically for around a year. Yeah.
Okay.
Then the other one was explain the symptoms of sepsis. Oh my word. So sepsis is a definition of a clinical syndrome that comes from infection. Typically, people have fever, but not everybody. Fatigue and like muscle aches, but not everybody. And then the unfortunate part is that they get low blood pressure, or what we say hemodynamic instability. They're unable to perfuse all their organs, so maybe they get confused, maybe they get acute kidney injury if it's a kidney transplant. They may have abdominal discomfort, and so but that is why when we say what infections do you have to take care of, if you have a fever, pills, any of these things that predate severe infection, that's when you have to have immediate attention in our population.
Okay. All right. Any other questions before we wrap up before the break? See if anybody has anything.
Hi, this is Shar. Can you hear me?
We can,
Oh,
yes.
yeah, we heard you now.
Okay. I have two questions. Can someone who cannot urinate get UTI? And my second question is, I currently have a graft, and it gets poked routinely. What is the best way to protect it or cover it? Right now, I actually just have a gauze over the entire area, and I put Tegaderm because I'm very nervous of getting any type of infection.
So, for one, can you get an infection if you don't make urine? Theoretically, yes. It would be a hard thing to be determined. People might have tenderness over the bladder site. And but usually if that infection happens, people think it's almost a kidney infection, like pyelonephritis. It's possible. And the treatment of oral antibiotics may not, it could be very effective, but sometimes it's not as effective as if you're making urine, because the antibiotic goes in the urine and provides some assistance there. But the answer is possible, and it would be difficult to diagnose. Okay, it's a challenge. And regarding the vascular access, of course, all the things about maintaining cleanliness, what to wash before the site gets cannulated. And there's a lot of arguments what to do over a graft for sure. You don't want to wrap it in a way that would be tight and reduce flow, and then the thing clots. If you wanted to put any kind of gauze or covering over it and it isn't tight, that would be fine. It would prevent any kind of environmental kind of things going on there. But typically each of the dialysis centers has their preferred, they put on your bandage when you leave, they tell you to change it at a certain time, etc. But if you add a gauze over it, it would be fine. Just don't do it too tightly.
Thank you. That really helps.
Okay.
Good question, Char.
Well, thank you, Dr. Paul.
Thank
and
you.
everybody, Dr. Paul is a board member of Renal Support Network and always willing to help people who have kidney disease, whether they're her own patients or other patients or community organizations like we are. So we're very grateful for her.
Well, and I'm grateful to be part of this wonderful process. Thank you for inviting me. Okay. Bye, guys.
See you later.
Thank you,
See you
Dr.
later.
Paul.